Mohs and superficial radiation can both treat selected skin cancers, but they solve the margin problem in fundamentally different ways.
Right off the bat, that exact conflict is what drives the whole decision-making pathway we're exploring. It literally all boils down to one thing. How do you get certainty about your surgical margins, and, what does that ultimately mean for your skin over the long haul?
This explainer was written and edited by Dr. Thomas Hocker, a triple board-certified Harvard and Mayo Clinic-trained dermatologist, Mohs surgeon, and dermatopathologist.
Okay, wait, hold up. Before we get way too deep into the clinical weeds here, what is the absolute bottom line? Like for a patient actually sitting in the clinic trying to choose, what is the biggest difference between the two?
Well, the short answer is exactly how we confirm the cancer is actually gone. With Mohs surgery, we are actively examining mapped surgical margins during a single procedure. You get immediate, microscopic proof that the specific tissue we removed is completely clear. Now, radiation is a totally different ballgame. It treats a field right in place. There's literally no margin specimen removed at all. So control just has to be judged by observing the area over time. This isn't just some minor technical distinction, it's a huge difference. You're choosing between immediate microscopic proof on one hand and establishing success through long-term observation on the other.
So let's jump right into Section 1, how these treatments work, the mechanism. To really grasp why that immediate microscopic proof is such a big deal, we need to break down the step-by-step reality, starting with Mohs. The Mohs mechanism is this incredibly precise sequence designed specifically to save as much healthy tissue as possible. First up, the visible cancer and a super thin layer of the surrounding tissue are removed. Then, and this is the crucial part, that specific tissue is mapped out and the peripheral and deep margins are examined under a microscope, all while you're literally still sitting there in the office. If we see any cancer remaining, we go back and remove another layer, but only from that specific involved spot. Finally, once those examined margins are proven 100% clear, the wound is repaired or allowed to heal naturally.
Now let's look at superficial radiation, specifically modern image-guided superficial radiation therapy, or IGSRT. This operates on a completely non-surgical pathway. First, they use high-frequency ultrasound to sort of estimate how deep the visible tumor goes. Then, ionizing radiation is delivered directly to the tumor and a planned-out field of the surrounding skin. You don't just do this once. It's delivered over multiple fractions, meaning multiple visits. But here's the absolutely critical difference. While ultrasound is great for estimating depth, it does not give you a microscopic margin specimen. Because of that, the treated field just has to be monitored over time to figure out if the cancer was truly wiped out.
All right, let's do a quick mid-explainer reset here. We get that they solve the margin problem in totally different ways, but when we actually look at the cold, hard data, which one of these actually has stronger long-term evidence?
Yeah, so this is where the paths really diverge. Surgery is actually the guideline-preferred primary treatment for most operable basal cell and squamous cell carcinomas. Why? Because it's backed by longer follow-up times and much stronger comparative evidence. In fact, there's a well-known randomized trial for facial basal cell carcinoma that clearly found lower recurrence rates after surgery compared to radiotherapy, plus better long-term cosmetic ratings. Now, quick caveat, that specific trial used older radiation techniques, so we can't pretend it's a modern randomized comparison of IGSRT versus Mohs. As for modern IGSRT, the reports definitely show promising high local control estimates, but we have to remember that evidence is predominantly retrospective and observational. There is literally no direct modern randomized trial right now proving that IGSRT is equivalent to Mohs for high-risk Mohs-eligible tumors.
Okay, but let's talk aesthetics for a second. Patients hear the word non-invasive, and they almost always assume that means radiation is completely scar-free. Is that actually true?
The short answer? No. It's really important to clear this up. Yes, radiation avoids a surgical incision, but it absolutely does not leave you with untreated skin. The word non-invasive is just not a synonym for no lasting tissue effect. Over time, radiation can actually cause very gradual skin and deep tissue changes all across that treated field. We're talking about late changes like hypopigmentation or hyperpigmentation, so lightening or darkening of the skin. You might see telangiectasia, which are those visible spider-like blood vessels. It can also cause tissue atrophy, fibrosis, hair loss, and significantly reduced tissue flexibility. And exactly how that ends up looking depends heavily on the specific site, the size of the tumor, and just how much time has passed.
Now contrast that directly with Mohs. With Mohs, we are creating an actual physical wound. The scar you get from that is often linear, or it might follow a flap or a skin graft. But here's the thing. Those scars usually evolve and improve immensely over the following months. That early redness, firmness, or contour change you might see right after surgery, that is absolutely not the final result. Basically, you're making a trade-off. You are trading an immediate surgical intervention that creates a wound that actually improves over time versus avoiding surgery up front, but dealing with tissue that eventually undergoes those late radiation changes.
Let's move straight into Section 2, comparing the treatment burden.
If we take a look at this burden matrix, you can see how the whole margin problem directly impacts your literal timeline. Mohs is typically delivered in just one single procedural course. It's usually done under local anesthesia, and sure, sometimes it involves multiple mapped stages, but it's almost always in a single day. Plus, if, worst case scenario, a recurrence happens way down the line, your options for additional surgery, radiation, or other care are still wide open. Superficial radiation, on the flip side, doesn't require any surgical anesthesia, which is great for some, but it does require multiple treatment visits spread out over several weeks. And a major point to consider: if a recurrence happens after radiation, salvage surgery becomes significantly more complex. That's because the tissue has already been irradiated, and your options for repeat radiation are usually pretty limited.
Which brings us to Section 3, making the right choice.
Taking a step back, how does a doctor and a patient actually synthesize all of these variables? The evidence, the scars, the margin mapping, the multiple visits. How do you actually make the right choice?
Well, it's about context. Radiation is actually a highly valuable, guideline-supported option in specific scenarios. For instance, if surgery is medically unsafe for someone, or if it would create a totally disproportionate burden for a frail patient. It's also a completely reasonable choice if a patient just wouldn't be able to tolerate the anticipated surgical repair, or if they simply make a fully informed decision to decline surgery after they understand all the differences in evidence and late tissue effects. Oh, and it remains super important as a postoperative adjuvant treatment when we're dealing with certain high-risk features.
But if we're looking for the direct, objective recommendation, that remains pretty clear. For a healthy surgical candidate dealing with an eligible, high-risk facial basal cell or squamous cell carcinoma, Mohs is generally the stronger choice. Why? Because it physically removes the cancer, it examines that mapped margin while you're still in the operating chair, it preserves all the uninvolved healthy tissue, and it hands the reconstructive team a beautifully cancer-free wound.
Right, so for everyone watching this explainer right now, what are the exact, specific questions they should be bringing into their consultation to make sure they're part of a truly shared decision?
You should absolutely ask your clinician if your specific tumor is considered high risk. Ask them exactly how you will know the cancer is truly cleared. Ask what the expected late skin changes are for your specific anatomy, and importantly, what the exact plan is if the cancer happens to return. Because remember, and this is absolutely crucial, no treatment guarantees the cancer will never come back. Regardless of the path you choose, both of these require long-term recurrent surveillance and ongoing skin cancer monitoring.
So what's next? Well, we highly recommend you read the complete evidence-based article over at skintrust.com and use that to discuss your individual decision with your treating clinician. Just a quick reminder, this explainer is meant for general education, and it doesn't replace personal medical advice.
Ultimately, the provocative question you have to ask yourself is this: do you want immediate microscopic certainty, or are you more comfortable monitoring a treated field over time? As you think on that, remember that Dr. Hocker created SkinTrust to provide free, evidence-based dermatology education and help patients and clinicians make clearer decisions together.